Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs that practice orthodontics. Hi, I'm your host, Dr. Ed Gonzalez. The sponsor of our show today is the American Orthodontic Society. This is episode 6 of Orthodontic Smiles. For this broadcast, we are honored to have Dr. Leonard Carapezza. We hope you enjoy Orthodontic Smiles. Through our interviews and segments, we will innovate, educate, and inspire you and your staff. Our guest on Orthodontic Smiles could easily be credited with and popularly be referred to as the father of early treatment orthodontics. This Boston area native and pediatric dentist has practiced his special style of early treatment orthodontics in his Wayland office for 50 years. For 35 years, he has faithfully taught other pediatric dentists at Tufts School of Dental Medicine. He has spoken at over 200 dental conferences all over the world and has authored countless numbers of articles and has been awarded countless numbers of awards. He is a member of the American Orthodontic Society and is a diplomate of the American Academy of Diplomates and is the president of the Academy Board of Examiners. Orthodontic Smiles has tried to bring you dentists that you could consider famous, interesting, and educational. Dr. Leonard Carapezza is all of these. Today, I'd like to welcome Dr. Leonard Carapezza. He is one of the members of the American Orthodontic Society, but more importantly, he, I think, could be credited with being the man who has developed what we refer to today in orthodontics, and that is early treatment orthodontics. He's been doing this for many, many years, and I think remarkably well. How did you get started, Lenny, in doing orthodontics?
Well, basically it goes back to my early years going through dental school. When I graduated from dental school, I was billeted into the Navy, and prior to going into the Navy, I applied to a graduate program at the Harvard Children's Hospital program. And during that time, it was heavily, Vietnam was in play. And the director of the program said, well, if you're going to go in the service, I'll hold a place for you when you get out after your 2-year billeting. When I got out of the Navy after being a dental officer aboard the USS Wasp, which was the recovery ship for the Apollo Gemini series, I did all kinds of dentistry aboard ships. But when I got into my pediatric program, I was kind of bored after 6 months, and I gravitated to the orthodontic side, and I was seeing a lot of cases, kids coming through that were just randomly getting 4 bicuspid teeth removed without any orthodontic control, and a lot of the early interceptive problems that I saw could have been handled weren't getting handled. And so I got out of the program and opened a practice, a suburb of Boston, that I've been there for over 40 years now. And I started with one patient, and that one patient came in, was a 2.5 and 3-year-old. So my practice was built very slowly on that 2.5 and 3-year-old child. And lo and behold, practically every other kid that was coming through was showing some form of not an ideal occlusion for that age of development. So I staged the growth and development process into 6 stages, so to speak. So stage 1 was the primary dentition. Stage 2 was the 6-year molars coming in with the lower incisors. Stage 3 was between 7 and 8. And stage 4 was the bicuspids coming in and the canines. Stage 5 was the 12-year molars, and then the last stage was the wisdom teeth. But in any case, each one of those stages was showing problems of development in regards to the occlusion. So I devised a system of looking at the occlusion in regards to using angle system, class 1s, class 2, div 2s, class 2, div 1s, and basic the class 3s. But in the class 1 system, basically I broke that down into regards to 9 different types. Class 1 type 1 was a tooth to bone size discrepancy, which in those years was related to a lot of 4 bicuspid extractions. Stage 2 was the anterior protrusion. Stage 3 was basically anterior crossbite. Stage 4 was the posterior crossbite. Stage 5 was ectopic eruption. Stage 6 was deep bite. Stage 7 was open bite. Stage 8 was the transposed tooth. And stage 9 was congenitally missing teeth. So what I'm trying to say is I could classify every single type of class 1 malocclusion into those 9 different types. Some of the kids had more than one type in conjunction with the program, so to speak, there. So then I developed basically different techniques to handle that type of problem. And where that led to what I call the redirection of eruption, the serial guidance of the baby teeth to allow the permanent teeth to come in better aligned and with a better path of eruption and come in earlier.
But you aligned yourself with some style of orthodontics that was being taught back then.
Yes, but this was being done under orthodontic control. And that orthodontic control was I took Ricketts' basic philosophy of utility archway mechanics, and I developed that into my own type of system. And to speed this up a little bit, that system basically was taken up by an orthodontic manufacturer and developed the so-called preformed utility archwire. And that goes back basically with my hookup to Walt Brem, who was my mentor early on. And there's a good story there, which is probably a good time to plug this into the story right now, because when I entered in my private practice in 1972, across my desk came 6 Keys to Normal Occlusion, which is Andrew's article on that, and that led to the development of the straight wire appliance. And when I read that, the epiphany started. I knew that this was the way to deliver orthodontic care. And so in those years, I was sending my cases to the A company, which was the company developed by Andrews, and he was doing his lab assistant, or his assistant, was putting the bands for the prescribed bands for my cases together, because in those years we didn't have banding with direct bonding. Everything was done with bracketing, so to speak. And I did all the different types of orthodontic cases with Andrew's classification and system and so forth. And those cases just turned out so beautiful. I became a continual student of Andrew's. And to this day, I'm still his student. I'm going along also with his son, Will, at this time. And so I really feel, and I don't mean this in a bravado type, but there isn't anybody I feel right now, especially in general dentists or pediatric dentists, that knows more about the so-called fully programmed appliance by Andrews than I. It has been a proven product. It's been a foundation of the AOS. All of the major teachers that have gone through the AOS program and delivered that to their students have been well versed and trained in the so-called Andrews appliance, or the fully programmed appliance.
Well, there's no doubt about it that you have done a tremendous amount of teaching. I was kind of leafing through your curriculum vitae, and it was amazing for me to go through it, and actually I started counting the number of courses you have given over the years, and you've kept great track of them in your curriculum vitae, but there's over 200 courses you have taught. Well, some of them are 2 days, some of them are 3 days, some of them are 1 day, but it's just amazing to me that over your lifetime in dentistry that you have lectured all of them on early treatment orthodontics or some form of it. That's The number of lives that you have touched about early treatment orthodontics is amazing. That's why I call you the father of early treatment orthodontics, because before that there really wasn't much even said about early treatment. Do you consider yourself more a pediatric dentist or an educator?
Well, it's probably 60-40 now. I'm probably 60% clinical practice and 40%, academia. My basic in academia really is at Tufts. My responsibility there is, since 1975, has been teaching the pediatric graduate students the early treatment approach. The protocol of that approach is basically the following. It's early arch development. It's utility archway mechanics, which allows me to get proper overbite, proper overjet molar relationship. It releases the jaw, get lip seal, and a big part of that, as I mentioned, is serial guidance or redirection of rupture of the teeth. And then from that, we finish with the fully programmed appliance. So that's been my protocol. So when they ask me, what are your goals and objectives of early treatment, my students they salute me with this. It's proper overbite, proper overjet, molar relationship, jaw relationship, serial guidance, and lip seal. And then again, they know all the ins and outs of the Andrews fully programmed appliance. I'd like to feel when you deliver orthodontic care, there are three ways you do it. It's either growth modification, camouflage orthodontics, or orthodontic surgery. As a pediatric dentist, we own growth and development. Growth modification. We see that all day long.
Yeah, we have the opportunity to provide a treatment that the orthodontist is not able to provide, because they don't usually see the patients as early as we do.
Right, and not only that is that when you look at growth and development, it's three things. Growth and development is basically increase in size. Johnny got bigger. Decrease in size. That's lymphoid tissues, and then the third way is differential growth, and that's a big part. Okay, different parts of the body grow at different rates at times. Somatic growth doesn't go along with dental growth, so you can see some of these kids when they're 7 or 8 years of age, they may have a dentition or a 10 or 11, or it may reverse the other way. So years ago, when we were just taking out teeth to get resolved crowding, and then the child goes through a growth spurt, now you're wondering, why the heck did I take out 4 bicuspids? But now I'm locked in because the teeth have drifted back. So again, orthodontics it's really knowing a lot about growth and development, learning a lot about the eruption process, and we're not spending enough time in growth and development and the eruption of the dentition. The other thing being is that when we treat these kids early, there are 3 planes of space that we have to treat. We have to treat the transverse, the sagittal, and the vertical. And when you look at growth and development, what finishes first? It's the transverse. That's why everybody recommends treating the class 3s early, because that part we know that we can modify the suture of the maxilla, and that helps us in resolving some of these class 3 problems. The sagittal finishes second, and so sometimes we may need a late pupil growth spurt to help in the so-called true skeletal class 2 problem. But 90% of early treatment problems are dental alveolar, okay? And the key to that is that you have to unlock the occlusion, because if you don't unlock the occlusion at an early age level, it keeps the mandible back, and the mandible now rotates down and back instead of rotating downward and forward.
Well, so for the purpose of, hold on one second, for the purpose of those that are listening, when you say unlock the occlusion, you're really meaning expand the maxilla.
Expand the maxilla, plus now you have to get proper overbite and overbite. The key to this is the interincisal angle. Ed, this is, I've been a student of Andrews for so many years, and one of my sessions with Dr. Andrews, I said, Dr. Andrews, what is the most important thing that you look at in your finished orthodontic result? And he said, it's the interincisal angle. It tells me if I've got a proper overbite or a proper overjet relationship, and it also helps me to get to a good centric relationship position We want that mandible to be downward and forward in its correct position. Now, serendipitously, I'd come across a lot of this. Many years ago, I was given a talk at the University of Maryland for the Academy of Maryland Pediatric Dentistry. And at the end of my meeting, an elderly gentleman, probably my age at this time now, came up to me and he said, Len, he says, I really enjoyed your talk. Your cases are absolutely beautiful. But then he gave me the zing. He said, but you maybe don't know why you're getting such good results. So I tried to listen. He was the professor of growth and development in the orthodontic department. He said, I'm going to send you the treatise that was written by Bork in 1969. He says, in that treatise, you will see that if you get a good interincisal angle at an early age level, it causes the mandible to rotate down and forward. See, the mandible is a beast. It grows by rotational growth. It either rotates down and forward, which is a good growth pattern, or it rotates down and back. And if you have a deep bite and you lock the occlusion, it causes the mandible to get a clockwise growth pattern. So when you treat late and you've missed the growth, a lot of times you'll end up dentally class 1, but you'll still be skeletally class 2. Those are the type of cases that may lead to potential TMJ problems, or more importantly, a lot of the problem of orthodontics is that lower anterior relapse. So I can honestly tell you, with early treatment, my cases, and cases that are done by other students that I've seen coming through our board cases and so forth, they're dentally class 1 and it's also skeletally class 1, where the maxilla and the mandible are in proper relationship to each other. Now, I say with early treatment, 90% of the kids are going to end up that way. Now, 10% sometimes don't make it because of strong genetics or strong environmental issues. Then we have to go into what we call camouflage orthodontics. And that's what most conventional orthodontic treatment is done with camouflage. Even Prophet says that. He claims class 2 malocclusions, the gold standard, is late adolescent treatment or early adult treatment. See? So what they do, if you go into the literature and you look at these so-called board-approved cases and cases that are shown, as good results, and look at the steps on them, you'll see that a lot of them are dentally class 1, but they're still skeletally class 2 retruded maxillas, because conventional orthodontics sets up the mandible and then tries to treat the maxilla to that. Where early treatment, we develop the maxillary arch. Now, I'm using the word arch development, not arch expansion. And at an early age level, we're developing the arches. You can do that, see? You can do that. That's been proven with evidence-based literature at this time. Prior to the 60s, people thought you couldn't modify growth, but we know we can. People like Bork, Havel, McNamara have given us all of, the leads of evidence and based, on that. So again, early treatment really is a different protocol and a different strategy. And like I said, my protocol at this point in time is basically as a fixed approach. I arch develop with E-arches. I also use the titanium pellet expansion appliance in my class 2s, because that appliance, basically what it does, it causes expansion or arch development, I should say, and it rotates the molars. 90% of malocclusions have mesiolingual rotated of the molars. See? So one of the things you have to do with class 2 cases, you have to learn how to distal rotate and expand the molar, because most malocclusions have that mesiolingual rotated molar, and a rotated molar takes up space. It contributes to class 2 type problems. So again, the NPE does that. The NPE also can control the vertical. See, then I finish with the fully programmed appliance. It behooves me today why nobody, especially general dentists and pediatric dentists, aren't using a fully programmed appliance, because it has the first order bends, the second order bends, the third order bends.
It sure makes it easier, yeah. One thing you taught me that I still use, talking about advancement of the mandible after arch development, was that little picture that you show in your classes about the tennis shoe and the high heel. where the toes don't fit into the high heel. I always
Yeah,
use that with my
it's the shoe and the foot concept.
Right.
You widen the shoe, which is the maxilla, and the foot, which is the mandible, could fit into the shoe. That's why. Ed, the more you know about this, sometimes you get a little disturbed. Orthodontics is probably the best kept secret in the profession of dentistry, and it's based on politics. I should say economics first, politics and education. And basically, what happens sometimes the general dentist or pediatric dentist gets tied into the wrong. The media in regards to push. Right now, what you're seeing the media push with sagittal first, the so-called distalizing type appliances for carie and so forth. And, the education system tells us that isn't sagittal first, it's the transverse first, okay? You've got to develop the maxilla so that the mandible can adapt to that properly. So these are the things that sometimes the beginning student, it looks too easy, see, and then they get trapped into this, and then they may have a bad first experience, and then they don't want to do any form of orthodontics. So that's why it's important that organizations like the AOS, they have good sound programs and teach it the right way so they get a good foundation, and then you can basically build on your continual education, around that. You can't just take a one-day course, and then go out and try to do this. There's so much to this. It does require some discipline of learning and so forth, but it's easy. It's not a difficult type thing to learn, but you have to be exposed to the right educational system. It's not only that, the right people to teach you that. And I've been blessed. I've had a mentor in my life, Dr. Brem, basically, and how I got to Dr. Brem was that when I became a student of Andrews, and then during the politics that time, Andrews didn't want to know that he was teaching his assistant to general dentist. So basically, in those years, there were 3 people involved with the fully programmed appliance. It was Andrews, who was doing the teaching in his foundation, and he turned the orthodontist onto the straight wire appliance by Ron Roth, and the general dentist, grandfather in orthodontics was Walt Brem. In those years, Andrews gave each one of these clinicians a set of fully programmed brackets, which cost $1,000 each at that time. And the role was Roth was going to teach the orthodontist, Dr. Brem was going to teach the general dentist and pediatric dentist. So Dr. Andrews called me up one day and he said, I know you've been taking my courses, but I'm getting a lot of heat. A lot of orthodontists are saying that if Carapezza comes to these courses, they're not going to come because he's not an orthodontist. So that's basically when I got involved with Dr. Brem. Dr. Brem invited me to the Clinical Straight Wire Foundation in San Diego in 1975 to 76. And I brought my cases that I was doing all the different stages of orthodontics, class 1s, class 2s, extraction cases, so forth. I had a big trunk of them, and I brought them. I put them on a table in San Diego at the foundation meeting. Dr. Brem came by. He said, "This is unbelievable," and from that, he invited me to teach with him. And for 10 years, we taught at the University of Detroit in regards to a continuing program, the straight wire appliance. That was probably the best thing that ever happened in my professional career because I was really tuned into people that were really geared into learning and practicing the fully programmed appliance. So, again, and Walt and myself, we trained probably 3,500 more pediatric dentists and general dentists over the 35 years or so that I was with
And you're
Walt.
Still teaching, aren't you, Lenny?
And I'm still teaching. I like to tell people that we lost Walt, but I still have Walt's DNA in me in regards to. So when people hear me, I like to feel as though they're still hearing Walt Brem. He was just an amazing, dedicated teacher. He devoted his life as well to learning everything he could about the Andrews straight wire appliance, and he gave it. He gave it out. I mean, this is where the background of Bob Garrity and got his beginning knowledge from. Even Dr. Bill Wyatt early on was exposed to Dr. Andrews on that. But again, this is what the foundation of the AOS is, because the major teachers that carry through with the AOS are really grounded in the fully programmed appliance, which excuse me, is a tremendous result. I've had orthodontists come up to me, send me letters saying that these are some of the best finished cases they've ever seen. Norm Setland, who in this area in the New England was considered to be one of the finest orthodontists, he basically would sit in the back of my classroom in my teaching foundation here in Wayland, and he would say, "Len," he says, "I can't believe," he says, "your results that you're getting." And I don't know if I should say this, but he said to me one day, he says, "Len, I have my orthodontic colleagues are asking me, do you have anything on Carapezza?" In regards to, he became my staunchest supporter, and I could, just unbelievable, because I have such a high regard for Norm Setland and his results. And that's what I did years ago.
And you're passing it on, and that's what's so amazing, is that you're passing all of this on to your students. You have a course that you teach. You have a full comprehensive course you teach at your office. Why don't you tell us about that?
It's a 1-year program, but it has an option for 2 years. The beginning program, we basically start from nuts and bolts, and its first session is diagnosis and treatment plan. It's based on early treatment. It's an early treatment protocol, my protocol, and so forth. It's very sound, the diagnosis and treatment plan. That's the first session. The second session is Class 1 malocclusions, according to England, with the different types, the classification system that I devised. Also at that visit, at that session, it's basically the Class 2 Division 2s, which are the bread and butter, I think, of pediatric dentistry, because most kids have Class 2 Division 2 types of problems in developing the malocclusion. They're really Class 1s, but when you can unlock these Class 2 Div 2 type problems within 6 months using utility architecture mechanics and so forth. But that's the second session. Class 1s, Class 2 Div 2s. The third session is all the Class 2 Division 1s, and the fourth session is the Class 3s, with also a session of improving aesthetics through better occlusion aesthetic dentistry. Now, what I just mentioned, early treatment, 90% of those cases are dental alveolar. Even the Class 3s, to some degree, dental alveolar type problem. 10% are going to be skeletal problems, But again, if you reverse it, if you do late treatment, you're starting off with a lot of 90% skeletal problems, because these locked occlusions keep the mandible back, and if you go past the major growth spurts, then you're going to end up skeletally Class 2. Then you have to use camouflage orthodontics. Unfortunately, if some of these Class 3s don't get early treatment, and they're 30s and 40 years of age, and they really want to get treated, now they may be into orthodontic surgery. So growth modification is the bread and butter of early treatment. It's the bread and butter of a pediatric dentist or a general dentist doing early treatment. So again, when we look at these orthodontic cases, we look at molar, cuspid, midline, vertical. We treat 3 planes of space, the transverse, the sagittal, and the vertical. And our goal of treatment is to end up with a good physiological balance, with the soft tissues and in those 3 planes of space. So, really orthodontic treatment is not so difficult, but you have to have a systematic approach, and you have to be able to make proper decisions. And I like to feel I go back in my own training. I grew up very sports-minded. I was a quarterback, and everybody knows that what a big function of a quarterback is. You look at the defense, and I got to call the right play. Well, every month as we go through our orthodontic treatment, every month we're looking at these kids, and we got to call the right play. Molar, cuspid, midline, vertical. Molar, cuspid, midline, vertical. Transverse, sagittal, vertical. Soft tissue profile, so forth. most important decision. Do I need to take out teeth or not take out teeth? Early treatment, less than 5% are going to be extraction cases. You will go late, and when I started in the 70s, 65 to 85% of these cases were taking out permanent bicuspid.
Yeah, those were the days. I always found that strange to do.
And also headgear.
Exactly.
A lot of headgear.
Oh, that was awful. I keep a box of headgear that I
haven't used the headgear for over 25, 30 years.
I haven't either. But you know what? I have the box of headgears that probably has 20 or 30 headgears in the box, and I keep it in the office just to remind me of the aggravation I had using them. So I haven't used one in over 30 years myself. Lenny, I know that this year you're president of the Board of Examiners of the Academy of Diplomates, and I always love watching you when we give a diplomate his pin and his credentials for having achieved the highest level of orthodontics that the American Orthodontic Society can bestow. I love watching your face when the diplomats acknowledge the fact that you were their mentor. I think that's a tremendous compliment to you and what you've taught.
Well, the thing that I found, I was able to pass on to the diplomat board my research, what I did in the late 70s, after 10 years or so of working with the straight wire appliance. I did a study. I took 56 straight cases that were coming into my practice from other orthodontists because that were doing conventional orthodontic treatment. I took full orthodontic records, the straight line of what good records were taken in those years. And then I looked at 2 years of orthodontic straight wire cases that I finished, devised a grading system based on achieving the 6 keys to normal occlusion. And what was really satisfying to me, in 1989, Andrews published his textbook on the straight wire philosophy and concept. And he had a grading system for the 1,150 cases that he examined that were accepted by the American Board of Orthodontics and other board requirements. And his grading system was very close to one that I devised. And so I published that system and with my results in 1990 in the Journal of Clinical Pediatric Dentistry. So I feel very honored that the AOS accepted my grading system. So the candidates used that grading system in regards to looking at their finished results. And so I can proudly say that the cases in the last 3 or 4 years that I've been on the board, saying that these kids are coming through with the cases that they're showing that are showing those 6 keys to optimal occlusion. And basically those 6 keys can end. You can put your plaster on the table with any orthodontist in this country, and you get the 6 keys to normal occlusion plus a centric relation system. You'll have a mutually protected scheme of results that satisfies the mathological approach to orthodontics. And you can't ask for anything better than that. So to me, I'd love to feel as though that's my legacy that I've passed on to.
Well, you definitely have left a legacy behind in all of the years that you've taught and the thousands of dentists that you've taught. Dr. Carapezza, it's been an honor to be able to interview you this day. Orthodontic Smiles is very, very happy to publish this interview for all of our members and others all over the world to hear. So I want to thank you very much for doing this interview and being with us today. Thank you.
Thanks, Ed, for inviting me. As you can tell, I'm so passionate about this. I really feel that early treatment is such an important part of what we can give to the kids that are coming through here. And hopefully the pediatric dentists will get away from the so-called restorative end of dentistry, because this is what's going to stimulate them for 40 years out in regards.
That's true. That's true. Thank you, Leonard.
Thank you.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.